There's always a tendency of CNS medicine for the patient. So the drugs which are very good, have very good penetration, I think Lorla and Alectinib, and now the Lorla seems to be slightly better in terms of brain penetration. So definitely there's always a concern, and the side effect profile of the drugs also are a concern.
So CNS meds is an important issue. A significant number of patients get it at the baseline itself. 10 to 15% patients have it at the baseline, and a significant proportion of patients, at least 40 to 60% patients, tend to get it at some point of their journey through the treatment. Dr. Jimmy, your comments on the treatment with first, second, third generation lines and the resistant mutations which are now coming up, because we have now started with a lot of NGS, we can identify L-kinase domain mutations, we can identify other pathways which are getting activated. Your comments on that?
So, as we know more and more amount of the information on the mutations as well as the variants, so that we can conclude from that, and the treatment lineup we can decide from that. So better treatment lineup we can decide, and the best we can use first. That will be the policy for the all mutations.
So it seems that brain penetration is very, very important in ALK mutations. Again, I would like to correlate with some other disease. For example, ALL. We want to have some treatment for the brain because it is one of the century sites. CSF and brain are century sites in ALL. Similarly, collating, it's in ALK mutations as well. It's again a century site. We need to take care of that. Why do we need to take it from the baseline? Darshit sir, would like to highlight it.
So again, when you are getting better and better ALK inhibitors, you're seeing the relapses occurring more in the brain.
Yeah.
So that's basically what it is. So that tells you that you should target from the brain. Again, I'm sure you come to the LOLA trial and all that, but when you see the LOLA trial, you're close to 100% patients not relapsing in the brain, or patients without brain mets at baseline. That's significant. That's where you really look at the whole story.
So patients who are on this one of the particular drugs not progressing the brain, that is what we want to achieve actually in our patients. So these are the multiple things, OS data, CNS activity, overall efficacy, response rates, PFS, and I think we need a multitude of it. Nothing one is the final answer. Shruti, your comments?
I totally agree. We need all of them, and overall survival is as important as achieving a rapid response rate. And what's available second line, I would say would come next, because majority of patients, like you mentioned before, progress in the brain, and I will say more than 50% of them have a rapid deterioration in PS. So baseline brain metastasis, usually what I have seen is in ALK does not change the PS that much, but when on progression the patients have brain metastasis, they rapidly deteriorate. At that time, many times you don't have the option of giving an agent which is very, very effective. So delaying development of brain mets or not letting brain mets develop, should be a very high priority thing for the doctor as well as.
That is very valid point actually. What happens if the patient progresses in the brain? Most of the time these patients have poor neurological performance status and they are not fit to receive any further line of treatment. So that is one of the very important points, though it is discussed in some of the discussions that ALK is a forgiving disease. But what happens if the patient's progress in brain, which is eventually going to occur in ALK patients, then we have lost the battle. And most of the time you have to give supportive care.
And there's no way to know which it is going to happen to which patient. So if the patient is affordable, you should aim for the.
So now we come to the phase 3 crown trial results. This we have seen from last 2 to 3 years at least. So I'll just quickly go through it. Advanced lung cancer patients with PS0 to 2, patients with asymptomatic treated or untreated CNS mets were permitted. One or more extracriminal measurable target lesion were allowed with no prior addition required. 1:1 randomization, 100 mg only dose, stratified by presence of brain mets and ethnicity versus CRSF. Primary endpoint was PFS by investigator. So if you see this 18-month data, again I would like to come to Darshit. Darshit, there is a data of 18 months and there is again a data of 36 months. What do you think with this data and the separation of the curves?
Definitely, sir. There is enough evidence to show that lorlatinib versus there is. I think there is no comparison only now. It is far superior as compared to crizotinib, and the PFS at 36 months is not reached. And we can see that the curve starts very separating very early, and definitely difference is maintained throughout.
Yeah. So as highlighted by Darshit, the curves are separating early. As early as 3 to 4 months, the curves are getting separated. Vamshi sir, your comments on this? Early separation of the curve, why, how this is happening while, crizotinib has PFS of close to 8 to 10 months, but still?
So again, PFS is always medium. So you're going to have that small subset of patients who will be either rapid progressor, who will have some codependent mutations. Now, when we started the whole crizotinib story, we didn't know that there were different mutations. We got to know after a while. So that's possibly where the LOLA is working better, because LOLA has a broader coverage. So again, you see the first 2-3 months is actually slightly dipping for everyone. So again, even with LOLA, there's that small subset which will not do well, but otherwise everyone is doing well. That's how I do it.
Yeah. Also, now we are trying to, we are now understanding the various nuances. That means the variants of ALK, we know the prognostic significance at least. Also, we know concurrent P53 mutations. These add to the poorer outcomes in ALK patients with crizotinib alone, which doesn't respond. So those might be one of the important factors.
I think that's a very important point. When you look at the variant, you have to ask what type it is. That sometimes, mostly only the big panels are giving us that report. Many of the labs are not really reporting which variant it is. That's one more thing
we need to ask.
We need to
ask the lab. Most of the time they report. Darshit, you would like to see again the patients, the survival in patients without brain mets. Is it benefiting patients only without brain mets, or is it in brain mets, or both? What do you think?
Definitely, sir. Irrespective of brain mets, lorlatinib is much superior as compared to crizotinib, irrespective of brain mets. But definitely, when we have brain mets, I think crizotinib is very, not a great penetration in brain. So lorlatinib is the drug.
Yeah, so hazard ratio is tending to benefit more the patients with brain mets actually as compared to crizotinib. Since we are comparing with the crizotinib, which has less cranial activity, very less actually, so you can see patients without brain mets have hazard ratio 0.29, which is also very low, but still patients with brain mets is going towards 0.2. So that means the benefit in brain mets is huge. And these are the median PFS values across the trial. So cross-trial comparison are not usually done, but we always try to do and try to understand, because head-on comparison with other drugs are likely to come up. Shruti ma'am, your comments on this when we compare the 3 pivotal trials?
So all the comparisons are quite unfair. They have been done with crizotinib even when we knew that crizotinib is inferior to the other molecules. But because one comparator is same for all of them, we can actually do a cross-trial comparison of our own. And here also clearly we can see that the Crown has done better as compared to Alta and Alex. Now it is a matter of side effect profile and again the availability and all that. So side effect profiles are very, very different for all these 3 molecules, like for alectinib, hepatotoxicity, or for brigatinib, pulmonary toxicity.
Coming to toxicity.
Yeah, exactly. So, but looking at the median PFS data and the hazard ratios, definitely it is standing out for latinib.
Yeah, so I think apart from EGFR, where osimertinib show up hazard ratio of 0.2, we have not seen hazard ratio of 0.2 in other drugs, to be frank. But here in ALK, we have also seen hazard ratio of 0.2, close to 0.2. In brain mets especially, hazard ratio of 0.21. So that is actually not shown in any other trials till now. Hazard ratio at the best is either 0.5 or 0.48. So this is the hazard ratio which has been, you can see, it is improving from 0.45, then it got 0.55, later on coming down to 0.51, now 0.21. So that is the quantum of benefit which we are seeing actually now with the lorlatinib Crown trial data. Now, this is the projected PFS, though the data was not mature, that is why we need to do some projections. And it seems that projections are clearly benefiting this drug, though again, it will be a cross-trial comparison. Dr. Jimmy would like to comment on that?
Here what we see, the PFS data is persistent with the lorlatinib, and it gives the good PFS at the 3-year also. So I think the lorlatinib giving the good response. As the more data will come out, we will get to know further how much is the impact continues further.
So it seems that the control and the sustained control is more significantly, you can clearly see with lorlatinib. It is not seen with so much with other of the 2 drugs which is there. Again, coming to the points, now with the availability of all the PFS data, and how will you make choice? Darshit, when you are considering a patient with brain mets, and one patient without brain mets. Do you have some difference in the mind while selecting the first line TKI in positive patients?
I think with the patient, I mean we are not talking about cost for sure here. So I think when the patient is not without brain meds, we do give them option of all the four drugs, but preferably prefer them choosing either alectinib or lorlatinib. But when the patient is already brain meds, then we may explain them the data and the response in the brain, and depending on the side effect profile, depending on the cost and everything, then we let them choose the best therapy for themselves.
So we need to take care of multiple things, including cost, the toxicity profile, the size of the disease, the quantum of the disease, and also sometimes we take into account variants, though that it has shown only prognostic significance, but they do somewhat kill your practice in the mind. Vamshi sir, what do you think about the variants and other things when they come into your mind?
So again, type 3 will not respond to the earlier generation. That's the one thing we know for sure. Type 3 will definitely want to give electric or personally, again, looking at this data, you're showing the time to interact. So when you say that patients without meds, like I was mentioning, close to 100, just look at the top curves. Like almost they don't develop any meds at all. So that's the group where I'll be more keen to give a rather than those patients with meds. So this is a question which
here you can see the hazard ratio 0.08, which is just like a dream which we see.
No, so that's where the challenge comes, because the only question in my mind, or rather in a lot of people's mind, is should you give Lola upfront or should you give something like say Electric and then give a Lola? Personally, I'm more convinced with the Lola first hand. So last 3 patients have come, so they've already told for Lola, all 3 went to other places and took Electric first. It's just that my colleagues are not as convinced as I am. So I think maybe Pfizer should reach out to the people who are not convinced rather than someone like me who is convinced about it.
So again, if we see the patients who are already having baseline brain mets, again, that becomes very important. Shruti ma'am, would you like to highlight here the point when the patients are already having brain mets?
Yeah, so again, the intracranial penetration for lorlatinib is by far the best. But here again, we have that option of using alectinib first if you have brain metastasis. So, I mean, I am okay with both, but clearly the ground data in terms of progression-free survival is better, irrespective of the brain metastasis.
So, we have never seen a hazard ratio of 0.1, 0.08 in oncology.
Exactly.
And this is a drug which has shown so significant benefits that is beyond we have not seen it before.
See, Akhil, the hazard ratios are dipping so much because the comparison is with result.
Correct.
That's the thing. But yes, we are here talking about whether to use else. Yeah, I take your point.
So these are the update of the CNS efficacy of crown updates. Again, the intracranial responses are also very good. That is what we see. The patients with baseline measurable brain mets on the first line. You can see only one of the patient is having progression. Other patients, all patients have responses. You can see it is to the tune of 100% responses in most of the patients. 2 patients have partial response, one having stable. So that is actually quite convincing that the patients with brain metastasis definitely it's very huge benefit, which is definitely cannot be surmounted at the present time. Again, intracranial time to progression. This is data close to 100%. The patients without baseline metastasis, patients not progressing the brain is to the tune of 99%. So it's very again hazard ratio is 0.02. So just forget about the importance of hazard ratio here, because only one patient has progressed in the brain on lorlatinib actually out of the 112 patients who received lorlatinib without baseline brain metastasis. So again, if we see, now again, ma'am, you were talking about, because we are comparing with CRISO, the differences are so stark. Now, when we are comparing with other trials which are already available, what do you see? What do you think? Do you think the differences are significant? That we have
So, see, close to 40% of the patients will get intracranial responses. Here we are talking about 72%, and also close to, half of them will have a complete response. So, definitely when we do this comparison, the data is still standing out.
Yeah.
But there are patients who are going to, benefit with alectinib also, and the whole thing is whether you need to sequence or not sequence. That is the main point.
Yeah. But when we see the person, PFS here, time to progression in the intracranial, in Alex trial it was 40.5 and here it is 72.8 in patients with pacemaker. So it's actually a huge difference. It would have been 40 versus 45, then I would have thought that because these are cross trials, it might be difficult to compare. But these differences are actually seems to be very correct.
Much.
Yes, continue. Even in patients without brain metastasis, 50 versus 100. So that is a very significant difference. So Darshit, would like to add any point here?
I think ma'am has covered.
So it's very clear. I think there are some reputations. We are very convinced about the efficacy of the drug, and we'd like to come to the part where there are some questions. So again, coming back to the ALK variants, also ALK variant typing in the routine practice, and what is the benefit of lorlatinib sustained across the ALK variants? Dr. Jimmy would like to comment first on ALK variants. Do you always try to get a report of ALK variant in your patients?
No, in my routine practice, I just
Routine practice, yes. I think in the routine practice, we do not focus so much, but now with availability of good quality NGS, we are now trying to get, and also in the whenever we are discussing the patient molecular tumor boards, it becomes more focused and we tend to get because at the end, the treatment is not getting selected based on ALK variant usually, but at least it has prognostic significance. That is very, very clear. Darshit, you would like to add anything?
Yeah, definitely, sir. We are not doing routinely, but maybe in the near future we may have, they have prognostic significance. But routinely we are just doing NGS and we are not looking into variants specifically.
But now in our TMH reports also, the ALK variants are routinely recorded. So now ALK variants are being identified clearly. Yesterday in molecular tumor board also we discussed about the same actually, and we were on the same page that ALK variant reporting should be done if feasible within the resources. Shruti ma'am?
I agree with you.
So now, when ALK variant becomes more uniformly done in the routine practice, then it comes into the picture where the efficacy of one particular TKI is same across the variant or not. We know some variants are doing poorly, they will have somewhat poorer outcomes, whatever you do, but yes, then comes the importance of this variants. So this is the data actually from the Crown trial. We can see the variant 1, 2, 3, and you can see in the lorlatinib the response rates were close to similar, 70 to 80%, and duration of response were not reaching any of us. So we need to wait for the larger duration. And variant 3, you can see it is 33.3 months, which has been reached. So this is the variant where the least progression-free survival was expected, and it has come in that way also. But at least it is 33 months, even in variant 3, which is the most poor subgroup which we understand. So one of the poorer group having a median PFS of 33 months. Is that strike a bell, Dr. Ramshi sir?
Sorry,
variant 3 having median PFS of 33 months. So
it's definitely very good.
yeah, so it's very clear that even poorer prognostic groups are having very good responses and sustain a good PFS with even lorlatinib in the first line. And if we see this subject, and this is because the not duration of response were not reached in most of them, median PFS was not reached in variant 1, and it was 7.4 months in Crizo. For variant 3, Crizo was giving just 5 months of PFS. That is what I was talking about when we were seeing the curves, why PFS of Crizo is so low in some of the patients. So it might be related to variant 3, it might be related to P53, it might be related to disease burden also. It might be related to baseline brain metastasis, large brain metastasis which is causing. So that are the harbinger of poorer outcomes. And also, we have analyzed our own data. Patients with significant liver metastasis at the baseline also do poorly. That is very, very established now. And we have published that data separately, apart from our own data of 440 patients, which was published in JTO this year. So again, if we try to compare with other drugs like alectinib and brigatinib, again, it seems that the patients with the lorlatinib version 3 is also responding better to lorlatinib, but this is again a cross-trial comparison. So now coming to the interesting part, a patient has progressed on one of the treatment of LTKI. Do you do a routine biopsy in such patients, Vamshi sir?
So, wherever possible, yes, I believe we should do.
Yes.
It is helping. Again, am I doing it in routine practice? Honestly, no, because for various reasons. Not really.
Logistics are very important.
Wherever feasible, I would want to.
Yeah. So if the, for example, patient's progress in liver, it becomes easy to biopsy the lesion, you see that liver biopsy can be done easily. It becomes much easier. So Darshit, what has been your experience at KMH?
Yes, sir. So whenever the patient has progressed from any else like TKI, we always counsel them regarding rebiopsy and prefer tissue biopsy. But sometimes patients are not very keen, and sometimes they have some progression in sites when we cannot biopsy. So, for example, brain or bones. So in those cases, we may prefer liquid biopsy, but we do offer.
Yes, we try to identify the mutations. Now there is a large database which is already available and it is clearly suggesting that resistant patterns is different for different TKIs also. So we are now tending to understand. And if we see the piezoelectric resistant specimen, most of the time it is I1196M. For serotonin, it is now a larger number is G1202R, which is now picking up with alectinib actually. And the good part is that G1202R is covered by lorlatinib. That is what we know from the time of our DM training, that G1202R is one of the gatekeeper mutations, just like T790M for EGFR. That is why we are able to cover that. And on the same premise actually, we are accepting osimertinib as a drug of choice in EGFR. Osimertinib versus afatinib. We are preferring osimertinib based on same premise that T790M gets covered in EGFR. But here I don't know why there is a reservation to shift to drug. I think the most of the time, in the back of the mind, we have the toxicity profile in the mind most of the time. Otherwise, there is no confusion that lorlatinib is a much better drug, because this is what we are highlighting. G1202R, it is just like T790M EGFR, and we are very convinced in using osimertinib. While here, we need to discuss why lorlatinib needs to be used upfront instead of other available drugs. So that is one of the points I wanted to highlight. So these are the sequencing alterations, and as we do clonal evolution, we have one of the trials, investigator-initiated trial at Varanasi. We are doing the sequencing, the resistance mechanisms in all the patients, and we are comparing at both tissue as well as blood, wherever feasible. Blood is mandatory, tissue is optional, wherever the tissue is. Because we don't know our own patient's data, and ethnicity is one of the important variations for resistant mutations.
So, Akhil, can I ask you, how comfortable are you with the liquid biopsy looking for these mutations in ALK? Are you doing a fusion analysis? Are you doing a...
So, it should cover both DNA and RNA. RNA fusions must be present because these are kinase domain mutations most of the time. So, kinase domain mutations should be identified. At the same time, you need to have an elevated tumor fraction in your blood detector, otherwise it is of no value. So identifying elevated tumor fraction, your NGS panel should have the coverage. So we have specifically designed a panel where all the ALK kinase domain mutations are getting covered. That is what I wanted to highlight. So this is lorlatinib phase 2 schema data where patients received at least one dose of lorlatinib to 28 ALK positive patients. You can see 28 patients treated with one second generation ALK TKI with or without chemotherapy. This is median PFS in the expansion phase. You can see the number of even median PFS was limited, 5.5 months. But when this is the benefit of using a pan inhibitory agent, that is again I wanted to highlight. Upfront lorlatinib can significantly delay at least on target. Off target resistance, any drug is going to actually fail. That will be due to mostly off-target mechanisms. But on-target mechanism, which is in our control till now, we can utilize lorlatinib to suppress emergence of all the ALK mutations. So now we have utilized, for example, lorlatinib the first line. Now, what to utilize at progression? Or we can say we have utilized serotonin as the first line, then what to do on the next patient. This will be more relevant to us because number of patients who are lorlatinib in the first line are somewhat limited till now in our practice, but they are now increasing significantly. So, Darshit, patient is on serotonin, patient has progressed. What will you do to start next line of treatment? Patient is affordable for
choice.
Okay, you would like to do biopsy as well?
Yes. So biopsy, yeah. So biopsy and NGS, and meanwhile when the NGS reports are available, and we will start for lorlatinib.
Yeah. So again, here I wanted to highlight, apart from ALK kinase domain mutations, what other mutations can be present? You can see the ALK compound mutation or bypass mechanisms these are very limited with lorlatinib. Bypass mechanism is around 35%. But if we see the MAP kinase pathway, TIC3 pathway, other cell cycle pathway, that is all the off-target mechanisms. These are much more common with lorlatinib. While with crizotinib, definitely these are much more relevant and more important to them. That is why after lorlatinib, you might not be getting benefit from doing the repeat biopsy and doing but it might be valuable if you are using, so you have some trial drug available, if you have some rare mutation. For example, I got a MAC exon 14 skipping mutation in a patient post lorlatinib also. So that becomes useful and important. That is the benefit of doing, but it is 1 in 100 patients where you get some targetable mutations. So this is was actually discussed if we do sequencing. Shruti ma'am, I would like to take your comment here that if you do sequencing with alectinib, the data is about 25 months with Alex. If you add lorlatinib in the second line, yes, we are getting a PFS of 31 months. With lorlatinib, we have already got a PFS at least more than 36.7 months. So based on this data, does it make a somewhat difference in your choices?
Yes, of course. Logically, it makes sense that rather than sequencing, because this is the arrows indicate different patients. So in the same patients, many times you cannot use a second line drug. That is the entire point of my preferring lorlatinib in first line setting, because you will not get a second colored arrow for that patient. So that is there, and this also makes sense to use lorlatinib first rather than using a sequence, because in your head you feel that you may get a longer life for the patient, but that may not happen.
Completely. So patients progressing and dropping out after having progression is very important in lung cancer. We have seen patients dropping out and progressing, and therefore there might not be always an additional arrow which is seen here in the real life of the patients. So we always want to utilize the best possible, the best foot forward in our patients. So now I would like to come to the adverse effects, which are the most interesting part actually, and all of us want to discuss that actually. So now coming to the lorlatinib CNS adverse effects, how much worried you are, Dr. Vamshi?
Not really. I mean, all drugs have effects which we are aware of them and we know how to manage it. So you tell the patients in advance that these things may happen.
Okay.
Make counsel them and tell that if you have any issue, please let us know immediately.
Okay.
So again, handful of patients where I've used, I have not found these mutations, these side effects.
Okay.
I don't have a very big number, but whatever I have used, I have not found these things.
Okay. Dr. Jimmy would like to add, for which type of patients you will be more concerned about the CNS adverse effects if you are starting lorlatinib in that patient?
So I think with the lorlatinib, the adverse event, the neurological adverse events are very rare, very less. And whatever the patient we have, we can make a follow-up and we can see whatever the side effects are there, we can manage it. Mostly the altered lipid profile, most one can count.
So one thing which I keep in my mind while treating patients with lorlatinib patients having already brain mets, if the patient is so much symptomatic that you have to utilize cranial radiation, then it becomes slightly dicey to utilize lorlatinib, because what happens that when the patient develops some adverse effects, whether it is due to cranial edema induced due to radiation or whether it is lorlatinib, it becomes slightly difficult to assess. But if the patient is not so symptomatic, you start with DEXA for some days, the patient's symptoms resolve, then it is very easy. So you can start lorlatinib because this drug is having so good cranial efficacy, that will take care of it. But if by chance the patient has already received radiation outside your institute before coming to you, then I am slightly worried of starting lorlatinib. That is the only patient where I am actually worried about CNS adverse effects. Otherwise, it might happen in one or two of the large number of patients which we are utilizing.
What I have experienced is that when they get a neuropsychiatric side effect and they don't have a brain metastasis, it's difficult to handle. So, I mean, when the patient has brain metastasis and has had all these things, there is a possibility that both the things could be causing the deterioration.
Yeah.
But if the patient is fine neurologically and has got a lorlatinib-induced neuropsychiatric issue, that is, maybe it was one odd patient for me, but it was difficult to handle.
So it becomes more difficult when the patient is
yes,
both.
but of course the hyperlipidemia part gets very well
Hyperlipidemia is actually a lab abnormality, and we have not seen any cardiac adverse effects due to hyperlipidemia.
Exactly.
Though we routinely utilize rosuvastatin in a large number of patients, because another point which needs to be highlighted is atorvastatin has interactions with lorlatinib. Better to avoid atorvastatin. You can safely utilize rosuvastatin, which is easily available, not a costly drug.
Only thing is that they get very, like grossly deranged, so we should be routinely doing those tests.
Yeah.
That is the
So
take.
that is part of the routine follow-up, including the CBC LFD, which we commonly utilize. We mostly do lipid profile at least every 2 months. That is what we practice usually. Apart from CNS adverse effects, one more point. If CNS adverse effects have appeared, and you had to stop the drug for some time, whether could you start the drug in any of the patients? What about the ground data and what about your experience? Anyone, Darshit would like to take that?
Yes, sir. I think we have around 12 or 13 patients on lorlatinib. Only one patient had that CNS adverse effects, and we tried to stop lorlatinib. When we restarted, they were not there, and they were usually mild. They're not that significant to affect the daily life, but they are there.
So again, an important point is to identify the adverse effect early. If you consult the patient, they or their relative, actually it will not be identified the patient himself or herself, that will identify by the relative. This is the same counseling which I do for ifosfamide-induced encephalopathy. Ifosfamide-induced encephalopathy can occur in any of the patient. Even the patient is having good GFR, it might occur. So I always tell the patient's attender who is continuously there that if you observe say anything like that, please report to me at the earliest or report to the duty doctor so that can be taken care of. Similarly, if you identify it early, hold the drug for some time and then reduce, most of the toxicity disappear and you can continue the treatment. That has been the crown update and presented in ESMO last year as well, that the patients had very good outcomes. Even when CNS adverse effect appeared, we had to reduce the dose by one step down to 75. Then these do not lead to a lingering of the side effects when the dose was reduced. So that is another point which I wanted. Apart from this hypercholesterolemia and this, any problematic side effect, Dr. Jimmy would like to highlight?
I have used in very few patients, so I does not encounter much.
Okay, Vamshi sir, any other important side effect which is very troublesome in some of the patients?
Other than what you have highlighted,
Yes.
I haven't had faced any.
Okay, actually edema is what we see very significantly, in some patients only, but when it has developed, we utilize every measure, for example, be it diuretic, be it anything, it causes some amount of pedal edema is significant, and that is actually a class effect of alkyl emitters. We learned it with crizotinib first, that is a class effect, and with lorlatinib also it persists, and that is important. And we need again a good counseling with the patients, and we need to highlight about maintaining proper steps to reduce the edema as much as possible. But yes, I have to reduce the drug dose to one level in one of the patients due to edema. So edema is also there, though it will be seen only if you have it utilized in at least 10-15 patients, then you will see. We have the database of 40 plus patients with lorlatinib and it is under publication, so hopefully that will come shortly. This is again hyperlipidemia, which I've already discussed, and there are those adverse events doesn't happen. So that is point which I wanted to highlight. Cardiovascular events are not higher with lorlatinib as compared to crizotinib. That is very important. And long-term intracranial safety, which I just told, ESMO Congress 2022, the intracranial efficacy was maintained with 99% without baseline metastasis, and no grade 4 CNS adverse effects were found. And CNS adverse effects are persistently reducing with time. These are mostly predominantly grade 1. Just be cautious, counsel the patients, but that should not worry you so much that you do not prescribe the drug at all. Otherwise, the patient will not have time to get any toxicity if the patient doesn't survive. So we always need to keep in the mind, if you reserve a drug, very good drug, for later lines the patient might not be able to receive it also. So that is very important. This is the safety data which is already present, and even if the same data which we see with immunotherapy as well, the patients which require discontinuation or dose reductions, the landmark analysis shows that lorlatinib dose reductions also didn't lead to any inferior outcomes. You can safely reduce the dose if required and fitting into the profile. So I think we have tried to cover most of the time, and lorlatinib is one of the preferred drugs, category 1 recommendations now. With this, I would like to end here. If any other additional point anyone of you would like to make, or any of the audience would like to make a view? If none, we can conclude. Yeah, Dr. Jimmy, go ahead.
So, if the patient who has the variant 3 and after the lolonidine, any new drugs that is ongoing trials?
So, phase 4, fourth generation TKI is under development actually. So, that drug is identified by a number presently, TKI something, TES, that is under development. Hopefully, we'll have the drug in next 2 to 3 years, but not very soon at least. So, that is. Thank you. Thank you everyone for listening.